Hi, Miss Lisa. So I had a chance to review things on your chart. We got the report back on your EKG today. It showed absent P waves, and irregular heartbeat, varying R to R intervals. Basically, what that tells us is that you have atrial fibrillation. That's kind of where your heart is beating very irregularly, and when that happens, it can cause a lot of the symptoms that you're experiencing, the shortness of breath with activity, the dizziness, those heart palpitations, or like your heart's beating, or even skipping beats. All of those symptoms that you listed are all symptoms of the atrial fibrillation that's going on currently. Now, AFib can be caused by something such as your hypertension. I see that you have hypertension and that you're taking 25 milligrams a day of the hydrochlorothiazide. And I was wondering if the reason why you're taking that is because you just tolerated that better than other antihypertensive medications, or if you've ever been on any other antihypertensives. Because specifically with atrial fibrillation, we want to put you on a beta blocker or a calcium channel blocker. Those are two categories of medications that are used to also treat hypertension, but they are the two that we prefer to use when a patient has atrial fibrillation. So I was wondering if maybe you had some problems with tolerating like the beta blocker, if maybe there was a specific reason why you wanted to be on the diuretic for an antihypertensive, or if there's any other history that maybe I don't know or we're not aware of. And also if you've ever tried like a calcium channel blocker instead, because those things can kind of help to narrow things down so we can make a few changes. Now that hydrochlorothiazide will definitely want to get changed to a beta blocker or calcium channel blocker. And then I'll have you follow up in 2 weeks. I want you to come back to the clinic. At that point in time, we will reevaluate your blood pressure. If you'd like to, you can also take them at home on a day-to-day basis and kind of keep track either mentally or write those things down. You can bring it if you'd like, but you don't have to. But I do want to see you back here in the next 2 weeks. We'll recheck your blood pressure in clinic. And if your blood pressure is still a little bit elevated, we might want to kind of make some changes. But at that point in time, I want to rerun that 12 lead EKG on you to see how things are going with your atrial fibrillation. I want to touch bases with you and see what you think of everything, how you're tolerating the medications, if there's any issues with the medications, anything like that. And from there, we can just kind of further adjust. Now, I did want to mention as well that later on down the road, let's say that this does not resolve due with lifestyle changes. Of course, we want to encourage a healthy diet, regular exercise, always with these kinds of things. But let's say the atrial fibrillation, it's still showing you regular next time when you come and we redo that EKG. At that point in time, we could also consider putting you on an anticoagulant. The reason why is because during atrial fibrillation, so you have the ventricles of your heart and then you have the atrium in your heart, right? So basically, when your blood is pumping through there, when you're in AFib, because it's not pumping correctly, some of that blood is kind of pooling in the bottom of the heart. When that happens, there's a chance for that blood that's just sitting right there to kind of clot and form an emboli. That's what we call it, is an emboli. So basically, when those things happen and then they kind of get thrown from the heart, they enter the circulation, they can get stuck in your arteries and cause like a pulmonary embolism, where it's something that's stuck between the main artery that goes into your lungs. It's something that is a leading cause of stroke in patients with atrial fibrillation. And so, yes, definitely a little bit more high risk for that. You also being a female, also around age 60, having that history of hypertension, it does put you at greater risk also already of having a stroke later on in life. You would be considered a high CV risk. So basically what I'm saying is, if these things don't resolve, we would want to put you on an anticoagulant medication. And that would just to be like a prophylactic type of medication, or a medication that we use ahead of time to kind of prevent things from occurring, considering that you're high risk. That way, we're not just waiting until something happens to get you started on something. But we'll just kind of keep a close eye on things for right now. I want you to keep in contact. If you start feeling extremely short of breath, if you are having severe chest pains, any radiating shoulder pain, things like that, I want you to go directly to the emergency room. Otherwise, if you have any questions or concerns, you can always feel free to give us a call. Send us a message on our little, patient portal thing. And otherwise, let's kind of see how that goes, and we'll kind of take it from there. One other thing too, I saw that we got a CBC on you, and I was wondering if you would also be willing to do a D-dimer as well. It looks like that was not run, just so that we can kind of rule anything like a pulmonary embolism out as being something that's potentially causing your current shortness of breath. So we definitely want to kind of just rule that out, and then after that, we'll just kind of, we'll do everything that we talked about, get you started on those new medications, and see you back in 2 weeks.